Yes, Sowmya.
Child's play, after all, pearls in the early diagnosis and management of pediatric ocular trauma. Um, it's not playing. Okay, so the objectives being we need to segregate what can be fixed in the emergency department and what requires OPD management. The challenges being the child is in pain, unwilling to be examined, anxious parents and doctors too, unclear history, unwitnessed trauma. So take as much history as possible. No forceful examination of the child. EUA may be necessary. So coming to ocular examination, it's very essential. Always do ocular examination of the affected eye also and the unaffected eye also. Take ocular examination, visual acuity record by Snell lens or e-chart if feasible, and check the eye movement in all directions because we need to eliminate any chances of any diplopia or muscle entrapment. So EOM movement should be checked in all directions. It's very important. Visual field should be checked in all four quadrants. Pupillary reaction, both of the direct reflex and the consensual reflex, should be recorded. RAPD, if present, should be documented. So as we know that males are more prone for any ocular injuries as they are more seen in outdoor activities and childhood labor. So coming to the injuries to the lids and adnexa, ecchymosis of the lids, secondary ptosis due to hematoma are seen. Cold compresses of the initial 24 hours is very essential. Lid suturing edge-to-edge closure is very important. Self-absorbing vicryl sutures should be substituted for the margins as it is difficult to remove the sutures without additional anesthesia in children. So involvement of the medial one-third canalicular injury, lid margins, tarsal plate, LPS muscle, ptosis needs immediate intervention. So coming to corneoscleral lacerations, this will be covered later in detail. So surgical management depends upon the type and extent of the injury, primary goal being watertight closure and restoration of the structural integrity, secondary goal being restoration of the normal anatomy and removing any vitreous or uveal tissue from the wound. Foreign body, if present, should be removed and documented. General anesthesia is preferred in children. Avoid any pressure on the group and use sterile BSS to remove any ocular debris from the surgical field area. So tear involving the visual axis is sutured with small suture bites in the center and longer bites in the periphery of the cornea. So when we remove the sutures, it will induce a uniform astigmatism by Rousseau-Hay technique. So suturing of the vertical and shelf wounds, it should be usually 1.5 mm in length, 90% in depth, and entry and exit wound should be perpendicular to the surface of the cornea, and it's essential to oppose the internal edge rather than the external edges, preferably by interrupted sutures. As shallow suturing can cause wound gape, unequal depth of suture, wound override, and full thickness can lead to microbial entry. So this is one of the cases of corneoscleral tear which was successfully managed, giving good visual acuity to the child. So the key points being have a good follow-up, examine for loose sutures, suture infiltrates, and remove the sutures after 6 weeks ideally. Remove the sutures from the steeper axis first and examine the other eye for sympathetic ophthalmitis. So white-head fractures are a subgroup of fractures which are seen in patients less than 18 years of age with little visible external soft tissue injuries, and it usually affects the orbital floor. So acute incarceration of the herniated tissue in a trapdoor effect occurs due to greater elasticity of bones in younger people. CT features may be subtle and indications of surgery being entrap muscle diplopia, enophthalmos, CSF leak within 24 hours. You can observe if above indications are not present and always tell the patients to avoid blowing their nose. So globe ruptures are very essential to be done surgery in the first come first serve basis. So the mechanism of injury being blunt, penetrating or perforating objects, conjunctival lacerations if they are present greater than 6 mm should be sutured with 60 vicryl. So in cases of occult scleral rupture or scleral tears, and in this case as we can see it is a corneal scleral tear, the principles of suturing being always secure your limbal sutures first, followed by the sclera and then the cornea. So it's always LSC pattern that we need to follow. So after securing your limbal sutures, for the scleral sutures, do a limited peritomy and always explore the wound. Wound exploration is very important to remove any foreign bodies if it is there, and always oppose the anterior and posterior edge of the sclera with 70 vicryl till the posterior limit of sclera which is visible. So traumatic hyphema in children, it's due to tear in the anterior ciliary body which causes bleeding in the anterior chamber, which can be managed by elevation of the head end of the bed, eye shield, decrease IOP, topical or systemic antifibrinolytic agents, and topical and systemic steroids. So coming to traumatic cataract, only traumatic cataracts with ruptured anterior capsule, we can plan cataract surgery with or without anterior vitrectomies. So in traumatic cataracts with corneal perforations, always suture the corneal tear first. Then plan the cataract surgery as a secondary procedure after the corneal wound healing is complete, say after 4 to 6 weeks. Keratometry reading of the other eye is preferred as there will be scarring of the affected eye. Primary posterior capsular rhexis is mandatory for all traumatic cataracts as there is high chances of membrane formation in these children. So 3-piece or rigid IOL is preferable to foldable IOL, and intensive topical steroid should be given in the immediate postoperative regimen. So in this example, as we can see, the corneal tear has been nicely secured first, and we planned for the suture removal after 6 weeks, and then appropriate keratometry readings were taken and IOL power calculation was done, and we planned for the traumatic cataract surgery, and the IOL implantation was done for the patient after 3 months, and this led to good visual restoration of the patient. So if any bacterial endophthalmitis is there due to trauma, it has to be managed on an urgent basis. Counseling the parents and children about the poor prognosis is important. Posterior segment injuries like commotio retina pustules, whiplash injury, traumatic rhegmatogenous RD and all have a very poor prognosis, and counseling the parents and child about the guarded visual prognosis is important. Traumatic optic neuropathy occurs in the age of 12 to 16, causing 3rd, 4th and 6th nerve palsies. So doing an MRI, referring to the neurologist, and counseling and reassurance of the parent and child is very important. Retrobulbar mass caused due to retrobulbar hemorrhage. It basically causes a rapidly increasing retrobulbar mass due to blunt or penetrating trauma, which should be managed by IV mannitol, IV steroids, acetazolamide and lateral xanthothermy. So for intraocular foreign body, as madam has highlighted before, the investigations play a very important role. So before planning for any pediatric ocular surgery, you should always keep the patient elbow out for 6 hours. To have an empty stomach and potential airway problems can also be avoided. And always take the anesthesia clearance, and if possible, always operate with anesthetist. So the take-home message being, most of the injuries sustained in workplaces can be avoided by discouraging child labor or by wearing protective gear in workplaces. Activities such as fireworks should be done under proper supervision, and better healthcare facilities should be provided in rural areas so the delay in seek of treatment is best avoided. Thank you.
Thank you, Sowmya. But as usual, you have missed the legal points. You have not taken the consent from the parents.
Yes.
That is very important. Whenever preparing the next time, when you are going to talk,
Sure, sir.
identification marks, type of injury, and the consent.
Yes, sir.
Take a slide that the consent has to be very important.
Okay.
Thank you.